Actually, I've fixed it. It's fixed. Okay, let's make a start. Assalamu alaikum wa rahmatullahi wa barakatuh. I want to welcome our audience to the British Somali Medical Association's invited lecture series. My name is Zakaria Mohamed Ashkir. I'm a cardiologist and the founding president of the BSMA. And I have with me today my good friend, Dr. Ali Bihi, who's a family physician and is our director of external relations. If this is your first experience or encounter with the BSMA, essentially we're a group of UK-based Somali doctors and medical students with the aim, firstly, to support each other, but also importantly, perhaps more importantly, the aim of addressing the healthcare issues facing the Somali community in the UK and also back home. We strongly believe that together we can achieve more than we can as individuals. And we've shown that in the last two years of our existence, we've carried out many successful projects ranging from widening participation to community workshops, for example, in mental health. And all of this we've achieved without any formal funding whatsoever. In the last year or so, many of our projects have been put on hold to help us focus on COVID and helping the community fight the misinformation and the vaccine hesitancy. And you may be aware of some of the great social media campaigns and some of the community conferences that we've held. But there's more to life than just COVID. And there's more to the BSMA than just COVID. And we have many exciting projects, one of which, of course, is this invited lecture series. The idea of the invited lecture series is that this is a program of lectures from expert and people of high esteem talking about issues that affect the Somali community, both here and also back home. As much of our audience is international, unfortunately this will be only in English. لكن هداد سؤال قبتد وأف Somali وأتقصو قوري كرتا. We will translate into English for our international listeners. And without further ado, I want to hand over to Dr. Ali Bihi, who's going to be the host of our inaugural lecture, to introduce Dr. Mohamed Jama.
Thank you very much, Dr. Zakaria Ashkir. It is my absolute pleasure and honor to introduce our first esteemed guest. His name is Dr. Mohamed Abdi Jama Beydhabo, also known as Dr. Beydhabo. He's the former Assistant Director General at the World Health Organization. He has 30 years experience of leading global health diplomacy and solutions at national and international levels. Dr. Jama is a Somali physician with postgraduate training in paediatrics and public health. He is a fellow of the Faculty of Public Health of the Royal College of Physicians. Dr. Mohamed Jama Beydhabo, the floor is yours.
Thank you very much, Dr. Ali Bihi. Assalamu alaikum to all of you. It's my pleasure to give you an idea of what is going on in our home country, how the health system is shaping up, and our goal of achieving universal health coverage. I'll be taking through you through the slides. I'll go and give you some ideas of the socioeconomic and demographic context, which I'm sure you are fully aware. The health status of the Somali population, the burden of disease, the challenges that we are facing, and the solutions that we have to address those challenges. I will also share with you the projected impact of the package that we have developed, the service package we have developed in the last 1 year, how it's going to impact on the lives of the Somali people. Now, Somali demography, you know it, the population is estimated in 2018 around 15.4 million. Somalis are urbanizing very quickly. 30 years ago, more or less, it was half-half. the rural, the urban versus the nomadic and rural population. Today, 51% of the Somali population live in urban areas. The nomadic population are 26, quite sizable number of people to be looked after. Somali people, the Somali nation is a young nation. More than 30% of the population are below 30 years. It's a young, this is a great asset to the people. If they are educated, taken care of, and given a vision and hope, I think the Somalia can achieve the goal, universal health coverage. The
Are you having difficulty moving on to the next slide?
Yeah, I'm not able to move the next slide. I don't understand why.
Oh, there it is. Yeah, it works now.
Yeah, okay, now it's working. Okay, thank you. So here you will see the demographic transition, and also it's the same as the epidemiological transition. Somalia is still dominated by high fertility rate. The crude rate is quite high. The life expectancy is low, below 60 years, and the GDP as of 2017, we were improving and nearly close to $500 per capita. But the estimates of today, which is not fully yet published by the government, is 225. So it has reduced. The COVID had a huge impact on the economic outlook of Somalia. There is a problem of moving the slides, so I don't know.
It may be that you have to press the center of the slide. There you go.
Okay. So now a little bit of a history. For those of you who remember Somalia in the 70s, this picture will recognize. You will see on the left-hand side, of course, this is also true today, a typical Somali woman in Somalia's rural areas that shows particularly, who need health services, both women and children are priority groups. On the right-hand side, you will see a gentleman, Ali Mao Maalin, who was the last case of smallpox in Somalia and in the world. Somalia was the last to eradicate polio, the smallpox. We are on the verge also of eradicating, polio. We are polio-free as of 3 years ago, and we hope to remain as such. This shows that the health system in Somalia at the time, because of the community outreach services that we were providing in the country, we were able to reach all the corners of the Somali territory. And that's why, the vaccine, the smallpox vaccine, could reach, all corners of Somalia. Although the health facilities and the primary healthcare system, the delivery system was quite weak, but still, with a good vision and the leadership of the Ministry of Health at the time, we were able to reach a large number of population, and Somalia could eradicate, which was a major achievement. This has laid the foundation of a primary healthcare services, which actually started that we can reach out to communities and even gave us hope to serve our nomadic population. Where do we stand today in terms of the health status of population? This is the data of 2019, extracted from global database of the burden of disease, hosted by University of Washington, the Institute of Health Metrics and Evaluation, complemented with the local data that we have been able to collect from the health information system in Somalia, and studies conducted in the country by independent scholars, both Somalis and non-Somalis. The data is not a good data. As you can see here, the mortality rate is quite high, but this has actually, it is half of what it was, let us say, 20 years ago. So we can claim that it's a downward trajectory, and we hope that to continue this way. I just want to take pause. If you can see the sources of the data that we have here, The SDHS means Somali Demographic and Health Survey. This is the first nationwide survey that was ever conducted in Somalia, involving 300,000 households, including both urban and rural, as well as the nomads. So it's quite comprehensive, except one region and few pocket, areas that were inaccessible. The rest of the country was reached, and there were 300 Somalis who actually conducted this survey, which is really provided us a good baseline data of all the information that you see on your screen. The under 5 mortality rate is quite high. Neonatal mortality rate is as well, and all the other indicators of mortality that you see in Somalia is still quite high. And for us to achieve the universal health coverage, we have to change this picture. The morbidity is also the same. HIV prevalence, luckily, Somalia is very low prevalence rate country. Because of so many other cultural, religious, factors that actually had impacted. If you compare with the neighboring countries where it is some of them double-digit, Somalia is still, blessed, to have a very low coverage, and this can go even down with the help of the whole government support and the communities. TB incidence is quite high in Somalia, has been like that for all, as long as many of us can remember. And malaria incidence rate is also very high. Hepatitis B and hepatitis C are also one of the main burden of disease in the country, in Somalia. But for that to be addressed, look at where we stand in terms of coverage with essential health services. The measles coverage, 23. This coverage will not stop transmission of measles. And that's why Somalia is having a cyclical outbreaks of measles, mostly affecting in the urban areas because it's highly concentrated, densely populated areas, and this is very high. Similarly, the pentavalent vaccine is only 12%. This is quite very low, extremely low. This is a nationwide picture, by the way. If you look at the breakdown, which is not what I'm going to show you now, but available in the public domain, you will see that the urban centers are reaching up to 50%, some of them 65%, but that's still very low. You need to reach 85 and 90% to stop transmission. So this is very low-hanging fruits that we can increase and expand the coverage surveys in the country. Now, there is a measurement unit that the global community has agreed to measure where, how to measure success regarding universal health coverage. There is an index that you can see here, the Universal Service Coverage Index in 2015, Somalia was only 22. This is a scale of 0 to 100. So we were as low as 22. But if you look at the average in Sub-Saharan Africa is 42. Of course, globally is very high, it's 64. And 10 years from now, Somalia has to change this picture. On the right-hand side, I'm showing you the strategy, the roadmap, the solutions that the country has developed 2 years ago, thinking of putting in place the vision and a strategy on how we can move and achieve universal health coverage in Somalia. The next slide is also showing the change that has taken place in the last 30 years. In the first 20 years, from 90 to 2010, the average change per year was very low, because this is the time when the country was, under tremendous stress and turmoil, conflict, and it has not moved much. But in the last 10 years, there's a hope. It's quite statistically significant, about around 3%. And that's why you see today is nearly 24% on this scale that is measuring 23 health indicators from 0 to 100 scale. Now, the data that we have been able to collect from the Somali Demographic and Health Survey, which was published last year, April 30th, 2020, you will see the significant inequalities in access of health services. You see the women and the different population groups, the lowest quintiles and the highest quintiles and quintiles, and those who are accessing health services, the different, vulnerable populations, children, women and children in Somalia. And you can see the inequalities here that need to be addressed with the package of service that we have recently developed. Now, there have not been many studies in Somalia. For example, economic analysis and health financing studies, the national health accounts. These studies were not done. They are in the making. But however, this slide shows you that 41% of the households in Somalia, they seek when they want to go to a health to seek health services, they go to the private sector. And that's quite significant. Nearly 49% of the urban and rural areas, they use their own income to pay for medical expenses. So that's almost 50% of the population. This includes also the nomadic population. 26% of the households in the nomadic community, they're also pay out of pocket because they are going to the private sector. And the private sector is associated with quality and care that's better than the public sector in Somalia. But the one bullet point is quite significant in terms of taking, our attention and focusing our attention here. 14% of households, they borrowed money from either a family member or from, money vendors, the Hawala system, or from businessmen. While 11% of the households that were surveyed, they sold assets, whether it is their livestock or houses or land, so this impoverishes the Somali population, who are already struggling with economic burden brought about, aggravated by the COVID-19, as you may have seen already. 2% of the households in Somalia are using health insurance. The health insurance market's not well developed in Somalia, and that is also another area of focus, whether it is social insurance, a scheme that has to be introduced, or other means that the private sector or the public sector has to develop together. Now, the burden of disease in Somalia analysis. We have used the latest data that was available to us at the time in 2019. And as you can see, the picture in Somalia, the burden of disease is dominated by communicable diseases, maternal and child health, and nutrition, disorders. Around 70% of our burden of disease. I just want to draw your attention the share of newborn deaths in Somalia, the burden of neonatal deaths in Somalia is quite high. Children, newborns who are dying before they reach 1 month, in the first 28 days. Because of poor attendance and visits by skilled birth attendants, and lack of access and lack of knowledge on how to also look after newborns that are in distress. Communicable diseases are becoming an important, burden to deal with in Somalia, and we will see it more. Their share of DALYs, disability-adjusted life years, per 100,000 population. Injuries is 7.9. This is very high. And injuries are caused not only by road traffic accidents, but also by gun violence and terrorism, unfortunately, in the country. This slide shows you 20 diseases are responsible for 85% of the year's life lost in Somalia. And if you look at them, and this also I'll show you the solution why it is so, that we are hopeful to address this. 47% of the total cause of mortality burden in Somalia are due to communicable diseases. And I have circled this for you. Lower respiratory, diarrheal infection, diarrheal diseases, tuberculosis, measles. We have the tools, we have interventions we know interventions that are cost effective, they can be scaled up, and this is quite, actually easy to deal with if, we all aim towards the same goal. The same is, the other diseases that I have highlighted in the infectious disease area. I have singled out here again the maternal and neonatal health. The same slide, 85%, or 20%, 20 diseases that comprise 85% of the year's life lost. Maternal, neonatal, and child health, and where they are. But look at the here where I'm pointing my arrow, my cursor. Proportion of women of reproductive age who receive modern contraceptives is 2.1%. It's very low. And I think it requires, a strategy that is culturally sensitive, acceptable to the community, with the support of our religious leaders and the community as a whole. Fertility rate in Somalia is very high, 6.3%, 6.3 children per woman. So this is quite high, and this has to be addressed by, through child, birth spacing, which is quite acceptable to the community. But I think it needs a strategy that's culturally sensitive, and that can be scaled up. Again, here, I'm trying to show you that NCDs are quite significant, also burden of the disease. The same thing I have said, injuries, diabetes, and others. The injuries here is, again, conflict and car accidents, road traffic accidents. But then what are the solutions? The proposed map I showed you is looking at the evidence that was gathered and has by prioritizing population-based intervention is both promotive, preventive, and curative, palliative, and rehabilitative care. We are using the health system framework developed by the World Health Organization, the 6 building blocks, because this is how we will measure ourselves. What are we doing when it comes to health workforce, the financing, the leadership, the information, medical, the information system, and the service delivery. All of these are input to the service delivery for people to access quality services. This is a very important slide that I want to share with you. And it shows you the survey that was conducted, service availability and readiness assessment, SARA survey that was conducted in 2016. And this picture is quite telling. It shows you the concentration of the health facilities and services from the central region of Somalia, Galgaduud, all the way to the Horn, as well as up to Zayla. Why is it like this? Why this? Can someone explain why this is the case? I think it is very clear. The peace dividend, when the local communities and the administrations in those areas have actually worked together, brought peace and stability in the area they are under their control, then the services can be developed and people and also the international community can support them. It doesn't mean that in the southern part there are no facilities. There are, but this is, actually is 6 years ago. We are going to do a new survey, which is in the making now. And I think this picture will change since, a large part of the southern part of Somalia is now peaceful and they can be reached. And those health services, health facilities that were neglected are being revived with the input of both domestic as well as the support that we are receiving from the World Bank, which is the first time after 30 years that the World Bank has returned to Somalia's health sector. Now, in terms of policy, and if we know the problem, what are we doing in Somalia? The government should have a vision to address those, problems. It should have, it should bring together its strategies and policies. So there were these policy responses that the government has developed: a national health policy, different strategies, guidelines, plans. Many of these actually were supported and developed with the contribution of the Somali diaspora. And I would like to mention and acknowledge Professor Khalif Bide and Professor Maya Omar, who have been instrumental in developing, together with the Somali nationalists and our partners, this groundwork upon which the system can be developed once you have a vision and a strategy and a plan to do so. And this is just to give you a list, not all of them exhaustive, but some of what has been done, so that Somalia has a vision to achieve this goal. Now, let me take you through the 6 building blocks, and quickly. We would like, first of all, by people in accessing health services, they should not suffer financial hardship. And that is one of the 3 goals of the universal health coverage. How are we going to do when a country has 2.6 million displaced people living and scattered across the country, who are a vulnerable population, and the poverty levels is quite high? The Somali government has thought about this, and they have a project called the Bahnano project in Somali. Bahnano is a social protection project where cash transfers are being given to vulnerable households in the country. It's not reaching everywhere, but I think the vision is there. The project has started, and it is actually working in major urban areas where the IDPs, the internally displaced people, are concentrated. There is an improved availability of essential medicines, vaccines, and diagnostics. Somalia even has started the vaccination, COVID vaccination using the Oxford AstraZeneca vaccine. But there is a lot of also counterfeit substandard medicines that are flooding the country, which is estimated around 30 to 40%. And we are trying to work with our neighbors through the African Union and IGAD to have a common approach on how we can reduce the counterfeit medicines that are crossing the border from all sides. We are going to strengthen the data capacity and health information system. There is an online virtual system that the country is using, where we need to expand. And this is called District Health Information System. It is the version 2 that we are using. It's a software developed by the University of Oslo that we are using here. In terms of leadership and governance and the advocacy, I told you about the vision, the strategies, the policies that were developed. But one thing that we would like to achieve, which is we have not touched, is pooling of resources. Resources that are coming from both domestic, which is quite negligible, very small, I must say, but also from our partners. Today, the fragmentation in the health sector is quite significant, and it's impacting, actually. It is one of the causes of inefficiencies in the sector. And the amount of resources going to the health sector actually is not buying good health for Somalia today. And this is not only the views of the Somali professionals and the Ministry of Health, but also our partners who are putting in money with taxpayers' money. We are engaging the private sector. Somalia has a very young private sector, mainly concentrated in the urban areas, and we are looking at that. And we are in discussion with both the Ministry of Finance, the Parliament, to bring them to their attention the need to allocate more domestic resources, although the revenue generation in the country is quite small. The COVID-19 pandemic has impacted in Somalia like anywhere, every country in the world. But in our case, we have actually managed to build our preparedness surveillance systems, the testing and laboratory capacities that were, for example, the coordination was very poor. We have improved the surveillance system that existed, which was created during the polio eradication program, is being, repurposed for detecting also the other notifiable diseases. But the laboratory capacity is what we can actually be proud of. Of course, mind you, it's a country that is now rebuilding its health systems. On the 16th of March, when the first case, 16 March 2020, when the first case was actually discovered in Somalia, the first COVID case, a gentleman who traveled from China, we did not have the testing capacity, although we had the knowledge. We had the knowledge, but we didn't have the instruments to use. So we could not do the molecular testing. And 6 weeks later, we had 12 PCR, machines and facilities that were working across the country. Today, we have 24 testing sites. It's a very small number, and you know, and we are trying to improve that testing capacity, so it's very low. And that's the significance why I wanted to show you that Somalia is also doing, trying to increase its testing capacity, its risk communication, accessing, you know, assessing people who are entering the country and requiring people to have a negative COVID coronavirus test. So now let me come to the main part of the gist of this presentation: service delivery. In the end of the day, visions, strategies, plans, they have to deliver services, and those services should include both the private and the public health sector, and they have to work together. What did we do in Somalia, since I and many colleagues were engaged in the last couple of years? We have developed and redesigned the essential package of health services. I'm using a bit of abbreviations here, but I will be happy to explain all the time when I'm on the slide. The essential package of health services 2000, which is now complete and is being published, was under development for a complete 1 year, actually 1 year and 3 months, 15 months. And we looked at the service. Once we have analyzed the burden of disease and understood what's killing the Somalis, we have designed a service and looked at the service coverage. We have decided to come up with interventions that can address those. We also planned a population coverage that will achieve and help us achieve the universal health coverage in 10 years from now by 2023, if the package is intervened. We looked also at the financial protection. So the next one is the same slide, but looking in a more graphic way. The service delivery component, you know, services are going to be expanded. The financial protection will be improved. Hopefully the Bahnano project and the cash transfer for the vulnerable population will improve, with the hope that, you know, the resources, both domestic and our partners, will increase. And the population coverage with these essential services will improve as well. Now, we looked at, you know, a myriad, thousands of interventions using the WHO USC Universal Health Coverage Compendium and the disease control priorities, these 9 documents that are packaged. Actually, the disease control priorities is hosted at London School of Hygiene and Tropical Medicine. So they are showing you the best by, you know, or the practices in the world and interventions that has been proven to have an impact. So what we looked at is what interventions can have an impact on the major health problems in Somalia. We also looked at the cost effectiveness. Are they cost effective? Are they affordable? And do we have the resources? And the third exercise that we did is, if we choose them, can they be scaled up? Can they reach the vulnerable population, the nomadic population, and the urban population? These are the 7 domains, the structure of the essential package of health services in Somalia 2020 that was actually published. And it's addressing all these areas. And we are quite realistic in our capacity and resources of what can be achieved under the current circumstances. We adopted a service delivery capacity that, as I said, which will include a mix of public and private sector. I'm repeating this point because before 2000, during the former regimes, there was no private sector. The whole health sector in Somalia was public sector, delivered by the public sector. But today, we see the public sector has to actually assume different functions, and the private sector has to be involved, both for profit and the non-profit organizations, the civil society, NGOs, and all that. We are also working within the Ministry of Health, a role shift. The Ministry of Health should be the policy making, concentrate to policy and strategic development. They should be the regulator of the regulatory frameworks of the health sector. And above all, when it comes to service delivery, they have to be the purchaser of services rather than providing the service itself. And this is quite a change for many of the tradition in Somalia. But still, the public sector will maintain the public health functions like surveillance, disease outbreaks, and the rest. We cost it. We need to know, because affordability is one of the key factors when you consider planning for service delivery. If you don't know what you can get and the resources that are available, then that plan will be simply another document that will stay in the shelf. So we cost it. We have used the costing tools that are available. The one we used is called the One Health tool, which you can Google and find out. And it is quite a comprehensive one that a number, 12 agencies have collaborated in using, and there are many costing tools that are available globally. What did we cost? We costed the infrastructure requirement, the drugs and medicine supplies, the logistics. Somalia, doing business today in Somalia is quite expensive. So we looked at the logistics, the human resources, thanks to large number of medical institutions, nursing institutions. There are a lot of people that are being trained in Somalia, but the public sector and the private sector have to absorb this large number of workforce that are being developed. And then we looked at what we call program support activities. These are the supervision, the health information system, the training required as we move on. Now, we came up with that in 2020, we estimated that the health sector has spent 105 million. This is a small amount of money, a small department in the Western world spends this much money. But for us, it's good enough. And we said that 80 to 90% of our health services actually can be delivered at the lower levels, as you will see. So this is how when we cost it, this is how we have distributed, and rightly so. We are going to spend more money into the medicines and other supplies. The human resources is the largest, as you can see. The human resources and medicines and other supplies are the largest components of our cost in the health sector. We have projected, was actually for us to have a vision, to visualize how much it will cost us in the next 10 years. So this is the amount of money that we will need each year. But what is important is to look at the per capita cost. And one will question, will this be enough? Can you deliver a package of health services at $8.3 US? What WHO normally advises is anywhere between $80 and $120 per capita, and this is far below. But I think for those of us who know the country, and for all of you, we believe that focusing on primary health care, given the epidemiological profile of the country, the interventions that are available and the cost of those interventions, we believe that we can achieve provide services to our people at this cost as it stands now. Can it change? Can it be more costly? Could be. The only 3 places that we have data of per capita expenditure in Somalia was in Somaliland, in Berbera, in Puntland, in Bosaso, and in Jubaland, Gedo region. There was a group of NGOs that we worked together and with the local authorities, and the per capita expenditure of 2019 was anywhere between $9 to $13 per capita. But this is the overall general, average that we assumed would be needed. It could change in the meantime. Where are we going to spend this money? This is the health delivery channels in Somalia, or the platforms, consists of 5 delivery levels. At community level, primary healthcare units, the health centers, the district hospitals, the regional hospitals. This is where, and of course the regional office, which is the administration where the regional management teams sit. So these are the 5 levels of the healthcare system in Somalia. And if you look at this slide, it shows you that nearly 80% of our resources will go from district and below. And that is where the primary healthcare services and the cost-effective interventions we have decided will have a huge impact. And that's why a deliberate policy choice that we have made in Somalia in 2020. Now, we also wanted, because we have several scenarios, and here you see S1, which means scenario 1. We discarded other scenarios because they are very expensive. This is a slide that gives you an indication. Given our means, our capacity, our economic means, if we implement what we have designed, it will cost us per patient per year the resource that you see, from cents to $14.3, at the regional hospital. So in a way, we can, be content in a way that this is the resource that we anticipate to be spent in the country, and that's how much it will cost. Now, if this package is implemented as designed, which we hope it will, with all the difficulties in some certain areas of access and the lack of resources and the economic downturn caused by COVID, then this is what we can expect. The tool that we use, the One Health tool, gives us an impact analysis, impact projections. And if you see the maternal mortality reduction that we anticipate, although it will not reach the goal of the universal health coverage, which is quite low, but it is quite significant. In 10 years, we will have maybe half of this is a national figure. And today, actually, the 692 per thousand live births is a national figure, but if you break down by state, you will see some of the states have actually are already at the 331. But nationally, that's where we are. But this is quite a dramatic, reduction, which can improve if we continue and stay, on course, that we will be able to achieve that. Similarly, the child mortality rate here, you see the neonatal mortality rate, the infant mortality rate, these are quite self-explanatory. Again, you see a downward trajectory of reduction of mortalities in all key indicators in the country. The maternal, again, the lives saved, quite significant if we implement, maternal lives saved and the child lives saved, in the next 10 years, if we really roll out properly and implement this program. The wasting and stunting in Somalia, unfortunately, is quite high. If you look at the wasting, 41% of the children today is the case. The stunting and the wasting is 13.5%. But you look at this, how we can improve if we implement this project. Today, there are child feeding, programs or feeding centers in the country, as we manage also the severe malnutrition cases, severe acute malnutrition cases at hospital level. In the NCDs, the trajectory, again, the projection is quite hopeful if we do it. Somalia is dominated by diabetes, in cervical cancer, prostate cancer, and also deficiencies like iodine deficiencies in certain areas that are cheap to intervene today. And this again gives us an idea for the policymakers and the financiers of the health sector to show them that if you do this, if you give us this money, if we implement this collectively, this is what we are going to achieve. I would like to stop here and thank you very much. Over to you, Ali.
Thank you very much for that very useful and detailed talk. We're also very lucky to have with us this evening Professor Maya Umar. He is a professor of health management policy and planning. He's also advisor to the government of Somalia. Before I ask him to give us his thoughts on the universal healthcare coverage, I wanted to first remind all the listeners that you can ask questions now. I would like all of us to participate by asking our guests to, answer some of your questions. So, Professor Maya, welcome, and the floor is yours.
Thank you so much. It is a privilege for me to attend this inaugural session, which is luckily we had a dear friend Mohamed to deliver it. And first of all, let me congratulate the young people who have established this interesting forum, the BSMA. Somalia, since it is history, the wonders that were done right at the time of liberating the country from imperialism and colonialism and all the way to the development that were mentioned earlier before the breakdown of the system were led by young people. When Mohamed and myself, when we were working in the Ministry of Health and in various institutions, we were as young as you are. We did our bit. and now we are your elders. All we can do is actually to bless you, to make dua for you, to support you, and to advise you. The country, as you know, has moved from the darker days to hopeful, prosperous times. And I was very hopeful to see the trend that was shared by Dr. Mohamed in terms of where we want to be in the next 20, 30 years. And these hopes are all really to be led and to be realized by the young people such as yourselves. I just wanted to make few remarks. I was looking at the epidemiological profile that was presented. One of the things that I felt was missing is the issue of mental health. Mental health is really an important health aspect, especially for Somalia. And I know that we are focusing on communicable disease control and to some extent the non-communicable diseases that were mentioned. But the comorbidities that could be linked with the psychological ill health and how they will impact and affect the health of the population should not be underestimated, especially with all the conflict that was going on, the displacement, the deaths, unnecessary deaths. So one issue is I would like us not to leave behind is the promotion of mental health and the treatment of mental illnesses. When the country broke down after the Civil War, with all sadness, I started to say, and I did discuss this with Professor Khalif and Dr. Jama at some point, said, why don't we look at this as an opportunity so that we can build a health system which does not repeat the mistakes of the past, that is more of tailor-made, responding to the needs and the realities and the context of our people. We have seen, you know, and I must pay a lot of respect when the government institutions collapsed. The private sector has come in and tried to fill the vacuum that existed at that time. But that has made us to pay a lot for what we have seen happening. We are now in a situation where there are proliferation of institutions, there is a fragmentation, not to mention the issue about the governance, which is the federal system, not clearly defining what the central government is to do and what will be the role of the federal states, and this has not yet been looked after. I think the issues that have been presented today and the strategies that have been laid down, to me, as someone who is coming from health system strengthening background, we need also to look at how can we improve the management systems, because I was listening to the scenario one that was presented, and Mohamed mentioned this was chosen because it was cheap. And are we to use the cost criteria, the cheap? Because sometimes you go for the cheaper option, but you pay high price at the end. You know, the Arabs say, al-baqil yakhsiru marratain. So you waste the little you have. So the issues about efficient management of the little resources that we have, and proper prioritization of what can be done and what needs to be done, and so on. I know the Ministry of Health is working hard. The younger people like yourself who are running the Ministry of Health are doing their best. In a very, very challenging situation. We were much luckier because we had a functioning, supportive government. You know, we could eradicate, I mean, all people like us at that time, we were young students, we were all taking part in immunizing people against smallpoxes. So we all contributed in the eradication of smallpoxes and the helping our people to get out of the droughts and those natural disasters, because there was a strong leadership. Another observation I have made is, you know, with the flourishing private sector, especially a private sector that is for profit, what will suffer is the public health, because you don't make profit by delivering public health services, and this is not going to be the interest of the private sector. Treatment for tuberculosis, for all the communicable diseases that are the causes of high morbidity and mortality. So how can we look at ways in working with this private sector, collaborating with the private sector, to address or to contribute in the public health aspect? So I will stop with those observations, and if at some point a question is asked and I can contribute in responding to it, I will be more than happy to do it. Thank you.
Thank you very much, Professor Umar. I'll just pass over to my colleague, Dr. Zakaria Ashkar, to ask a few questions.
Thank you. Before I do that, maybe Dr. Jama might have a few points to add to Professor Umar's excellent points that he's made. Or should we move on to questions?
Yeah, I just, if you can see what I projected, Professor Maya Omar, a dear friend and a colleague whom we have worked very closely in Somalia, said the right thing, actually, and I'm very grateful for his involvement. We had thought about because sometimes, you know, non-communicable disease and mental health are put together. And here what I am projecting, if you can see it, can you see, Zakaria,
We can, it's just small writing.
It's a small writing, and I'm trying to expand. Just want to show mental health and substance use disorder here, where we have thought about, this is what I'm showing is the package, actually. This whole thing, this small thing, is all the interventions. There are about 412 interventions that are in this package. And one of those interventions are actually the mental health, because Professor Maya Omar is absolutely right. Sometimes this is neglected and it's not supported. So I would agree 100% with him, the emphasis, particularly a country that has gone through years of instability and conflict, the prevalence of people suffering, you know, from mental health disorders are quite many, I must say. Also, what contributes to this is, unfortunately, the substance use in Somalia. What we knew was Saqat, but there are other substances that actually has, which was new in my time, in Maya's time, they were not there. But we understand that there are some controlled substances that are used in parts of Somalia that are grown, actually. It is the hashish in the lower Juba, middle Juba that we are hearing. So it is a very important, you know, burden that need to be addressed. Thank you. Over to you.
Thank you very much, Dr. Jama. I think, first of all, thank you to both of you for the great real education really on the situation in Somalia at the moment, and the way it may move forward, and to a situation where there is a decent quality of healthcare availability. And I think one point I wanted to ask is it's not I think people have noticed this expansion of the private healthcare system in Somalia. Somalis always are known to be excellent businessmen, so it's not a surprise that this sector has bloomed and has flourished. But as someone who's trained here in the UK and has seen how closely and tightly regulated everything is, I can't help but be concerned about who is going to ensure that the level of care and the level of treatment is standardized. When there are when the sector is dominated by private healthcare facilities, I understand that in Mogadishu, for example, there are many hospitals. I thought maybe there were 3 or 4. I mean, I know of 3 or 4, but I understand that it's many, many times more, and most of them are private. So what steps, what practical and plausible steps can this weak government take, and the next government that may come into place, take to standardize healthcare in Somalia?
Thank you very much, Mr. Zakaria. I think you are absolutely right. The future is encouraging the private sector to even develop more. The days where the public health will be the only service provider, I think it's over. In almost all the countries, and Somalia cannot be different. But what's different in Somalia is the weak legislations and regulatory frameworks, which are on the books now, in terms of either in the parliament to approve those legislations, or they are being developed as we speak. There have been studies on the private sector engagement in Somalia, and there are strong associations, by the way, Somali medical associations in, for example, Mogadishu, and they have different chapters in different, regions. There's a nursing association, there's a midwifery association. These people need to be nurtured, brought in, and not seen as sort of something that does not belong to the health sector, because we don't have the culture of working with the private sector in Somalia, but it's a reality today. And the public sector is catching up slowly, but surely, because the private sector is developing. Somalis are very entrepreneurship, business mentality, and they are developing. So what are we going to do? What's happening now are the legislations, the regulatory frameworks. There is, the national, recently the parliament has passed, it's the law of the land now, the National Health Professional Council, who is a doctor in Somalia, who is recognized as a nurse or a midwife, or etc. And what is needed is happening. We are developing also the quality of the services that are required, the assessment of the facility. Today, you have a lot of health facilities that are using instruments that can potentially radiate, although very small, like X-rays machines that are not protected. You need a special room. You can't put anywhere else, everywhere. So all these things we are catching up. And in fact, if you look, I don't want to compare ourselves with our neighbors, but every country in the developing world is struggling. We are very full conscious. We want the private sector to be an ally and part of the solution. And even we are bringing in the business community, who are now bringing medicines, importing medicines without any guidance from the Ministry of Health. So we have a long way to go, but we put all the systems in place. It is a matter of implementation and building confidence, because after long years of absence of government or any regulatory frameworks, there is a bit of resistance when you see what the government coming in. Are they going to take over? Are they going to stifle all the efforts that were done by the private sector. But surely, I think there is an acceptance of the private sector, not only for the profit, but also the number of it. And with the first, there's a contracting unit. The Ministry of Health never had this culture. There is going to be a contracting unit in the Ministry of Health that will contract out, the NGOs and also the private sector. Today, the largest TB treatment center is run by a colleague of mine, my classmate, Dr. Ahmed Goulet, who is actually contracted by the government to actually, he's a specialist in that area, respirologist, and he is the one who is doing that job. So it's coming slowly, but it's a major issue to be dealt with.
Thank you. I don't know if we lost Professor Umar there for a second. I don't know if he caught the question or if he wants to answer, add anything to Dr. Jama's answer. Okay. I think he's still maybe having some technical issues. I think my next question was, it sounds like the COVID pandemic in Somalia has actually helped the development of the health system, and it sort of spurred things on and accelerated its development. Is that a fair assessment?
I think in a couple of areas. I think the testing capacity that we do not have. Imagine the first case on the 16th of March 2020. The blood sample was sent to Nairobi for testing. But today, that's not the case. And in fact, 6 weeks after that, it was not the case. So there are a lot of Somalis who are trained but do not have the means to do so. So that has contributed. The surveillance system has allowed us to repurpose the polio surveillance offices that are scattered across the country because of the polio eradication to be used as, communicable disease surveillance officers who can report not only, polio, but also the vaccine preventable diseases and other notifiable diseases as required by the government. It's still building up. The risk communication. If you watch the Somali TVs, you will see dramas, you will see, talk about COVID, accessibility, musicians, the artists coming in. So there's a lot of work going on that COVID has actually pushed to the fore. But what also happened, of course, it's very unfortunate. We have lost very senior colleagues in the health sector who were infected actually because of they were the frontline workers. And it's quite painful that we lost, a lot of Somalis, over 1,000 people have been lost now. And particularly some of the senior colleagues, in Somalia, including the dean of the medical school in Hargeisa, who was a dear friend and a colleague. Many of them, I don't want to name, but because these are people who have invested their time, their knowledge to build the Somali education system and health sector. So yes, it has helped us actually to focus on areas that we would not have focused otherwise, like the laboratories, testing, and community, the risk communication and involving. So it has communicated, and also it brought together the governments, both the federal member states as well as the central government. Despite the disagreements at political level, on this area there is a common understanding and a common goal to really address the COVID-19 pandemic in Somalia.
Over to you. Thank you very much. I think we have Professor Umar who's joined us as well.
Yes, I was a bit disconnected. And was there any particular question you wanted me to address?
Yes, just the question. We can move on. Perhaps.
My connection is not.
Yeah. Perhaps Ali has a question that we can move on to, that you can answer first.
Can you repeat the question, please?
Yeah, I think Professor Umar will come back to you. We'll ask you another question.
My connection is getting frozen and every now and then. Sorry.
Sure. We'll come back to you, definitely. If I can just ask Dr. Jama, earlier on, you mentioned in your strategic priorities section that the importance of private sector engagement. When you use the word private sector, who are you referring to in particular? And the second question leading to that is many Somali locals and diaspora consider the involvement of international NGOs in Somalia, Somalia's healthcare, to be a hindrance and prevent Somalia to move forward in terms of its healthcare sector. Do you agree with that or disagree? And would you first start with the first question?
Okay, thank you very much, Dr. Ali. The private sector in Somalia, which actually started moving quite fast in the last 30 years, is owned by private individuals. They are mainly clinics where majority of the work is outpatient and also some laboratory testing, etc. And there are hospitals where patients are admitted. So some of them focus only on the diagnostic part. There are centers in Somalia where you only go for laboratory tests or any imaging, tests that you may require. So these are all owned privately by Somali entrepreneurs, medical doctors, who are managing and working in those areas. They have also, many of them, they have recruited foreign experts where they lack this expertise in Somalia. And few of them have actually brought in and hired, experts or doctors from outside the country if they were not available inside the country. The private sector in Somalia includes the pharmacists, and this is a major issue in Somalia. There is a very large number of pharmacies. There are a very large number of pharmacies that are manned by untrained, unqualified people who are just selling they sell, banana or cakes. And this has to be regulated. And this is where, the medicines and particularly antibiotics are dispensed without sometimes prescription. It's happening also in other countries, but in our country, it is a very difficult issue since we cannot control. It may drive also the antimicrobial resistance in the country. And it is a concern that we are trying to address, and we are trying to involve. They have an association in Somalia, the pharmacists. They are a very strong group, businessmen, I must admit. And now, as I said, there is a law in the parliament which has gone the first reading, I think, or second reading, about the Medicines Regulatory Authority. So that's one group of the private sector. The other group of the private sector are the non-governmental organizations, the private for non-profit organizations, civil society, who are also providing services. So this is when we talk about the private sector, we mean both the for-profit and the non-profit as well. Now, the history of the NGOs in Somalia, it happened elsewhere, in my experience, in countries that I have been involved in the 90s and in the 2000s. If a country, goes through what we have gone through, then NGOs descend into that country, for good or for bad. They are well-meaning and they want to provide services, but they also, in the process, create a lot of problems. There was an outfit created in our neighboring countries, run by NGOs, that were actually excluding, at the beginning of the 90s and early 2000s, the Somalis, where their voices were not heard. So I would, to a certain degree, say that perception or observation that NGOs have become a hindrance in Somalia in the past could, be sort of, I could agree up to that point. But I don't want to give a blanket agreement with that, because NGOs are doing some good work in Somalia, and we should not demonize them, but they should also not, sideline the national authority. In the end of the day, it is the national government that has the primary responsibility of giving services to its population, to its people, whether they purchase those services or whether they give directly. So that responsibility should remain. And in my experience, and I'm sure Professor Maya has seen it, there is some resistance. It happened in Afghanistan, where I worked. It happened in Sudan, where the NGOs who were sort of freelancing and doing a lot of work, both some of them not desirable, have actually at the beginning created some sort of controversy and resistance. But today, with the EPHS that we have, the Essential Package of Services, for the first time, there was one that was developed actually in 2009, and the Somalis have very little input to that, package that was developed, and that's why 10 years later, it could not show anything meaningful on the ground. Now, would this be different because it was led by Somalis? I'm hopeful. And I don't want to waste all your time, but I can assure you that we have encountered resistance, because also the sector delivery systems and financing is a shared responsibility between the Somalis and the international community. And we want to hear their voice. They are part of the solution, but we are not going to entertain further fragmentation and not listening to the Somalis, because the Somalis should have the final say of what needs to be done in the country. That is easily said than done, but I think it's coming together, in my view, from what I'm seeing now on the ground. Over to you.
Thank you very much. It would be great if we could have some quick fire questions from the audience. I mean, we're running out of time. We've got almost 10 minutes. So if anyone has a question, quick question with hopefully a quicker answer, please just raise your hand and we'll just open your mic.
Maybe we could start with some of the questions that people have been writing in.
Okay, go ahead, Zakaria. Can you read those for us?
So let's have a look at a question. Who are the leaders or the individuals working on this program back in Somalia at the moment? Who are the senior civil servants, I suppose, is the question here. I don't know if either Professor Omar or Dr. Jama can tell us who they may be.
Yeah, I think this is a good question, and Professor Maya will come in. I think maybe just to he mentioned this, how our federation is being built and how it's going to work. He has done a lot of good work for in Somalia, where the federal system that we have chosen has to deliver what is it for, with a different understanding of the complementarity and subsidiarity of the roles of the national and subnational level. Now, who's leading this? This is being led by the Ministry of Health at federal and state level, not one individual. It was an exhaustive consultation with the federal member states, including Somaliland, that was involved until late last year, where whatever policy documents that has been developed was the contribution of the Somalis and under their guidance. Actually, the co-chairs were all Somalis from the federal government, Ministry of Health, I mean at the Mogadishu level, as well as all the states without exception, who have provided their input in writing and also during the discussion. So we are quite satisfied that that ownership of the Somali people was really very strong here. We also involved the academia. We have shared this with the universities, with individuals in Somalia, with the private sector, and with the NGOs, both national and international NGOs. The NGOs, they have a forum of their own, and we have presented and invited comments and invited them in our meetings. We involved the Somali Association, medical associations, the nursing associations, as well as the other associations. So in terms of naming individuals, it's very difficult because there are hundreds of them. But these are the individuals, the institutions that were involved in that sense. Of course, I was part of that, helping and bringing expertise. And for the document that I was talking about is actually the contribution of at least 24 experts, in addition to the Somalis, because we did not have, for example, health economists in Somalia, at least that I know of. There are economists, but not health economists as such. So we had health economists, we had epidemiologists, Somali epidemiologists, we had public health and clinicians and public health experts. We had social scientists for the first time, where people in the medical field think that the social sciences have nothing to contribute in the health sector, and actually it's not the case. So all these things were involved at the leadership of the Federal Ministry of Health, but with the involvement of the federal member states, giving that space and role in the delicate process of building up our federation, so that everybody will have an input in and a say. So this document is familiar to everyone. They have it, they have endorsed, and we are very pleased now. The issue is how we are going to implement it. And I think here, if I may take one more second, I think I would invite our Somali diaspora, and now thanks to the British Somali Medical Associations, you have a role to play here, even without moving where you are, because your intellectual, professional expertise can provide, and we can connect you with the different people. And I think Professor Maye can also give you a lot of ideas of how you can get involved and help your home country to actually move on. I'll pass to Professor Maye, if you don't mind, Zakaria.
Thank you. Yes, I think you touched who the leading bodies here. I think the Somalis are leading, and both those who are in the country as well as those who are outside the country, like ourselves. We get consulted, and that is an important recognition of our role and our expertise. We do comment on the documents, and we do give our advice. The key is that enough? The problem is if you don't have the resources in your hand, regardless of the beautiful strategies and plans that you develop, which are absolutely relevant for your country, you might not be in a better position to implement this by yourself. So here you have the international donors who are helping the Ministry of Health and also the country in general, who also play an important role, and sometimes they could easily deviate you from what you consider to be the appropriate. Earlier I mentioned the fact that we wanted Somalia to come up with a system that is suitable for the country.
I think we may have lost Professor Umar there.
I think we've lost Professor Umar Zakaria. So shall we go to Dr. Jama for a very quick question, which I think we need to ask you before we finish this lecture. So you've talked about
Ali, just bear with me. I think Professor Umar is back.
Yes, I'm sorry, I lost you. So the other point I was making is, while the world is recognizing, let me take the issue of human resources, for example. In Somalia, we are having so many universities training and producing doctors today in large numbers, while we at the same time are talking about
I think, Professor Maya, if you can disable the video and perhaps use only the audio, maybe it will improve. Is that the case? Zakaria?
Yeah, I think, bear with me. I think
Is a recognition that non-medical doctors are playing a role in the delivery of healthcare services. For example, in the University of Leeds, we have got doctors' associate degrees now, which we used to have something similar, medical assistants, health assistants, and during the primary healthcare era, we used to have community health workers. I think we need to get back to these basics as much as we can. So Somalis can lead, but to some point. Jama mentioned about the role of diaspora. I think you can play a very important role here. I was working with a team in Ghana, for example, psychiatrists who work in the UK, and then during their holidays, they go back to Ghana and they train in Ghanaian universities. They train doctors, they train nurses. I think that will be brilliant if medics and health professionals who are overseas, who are in diaspora, can go and contribute in the human resources development work, in training, most importantly also in doing research and in also building the research capacity of our Somali compatriots there, which we really need. You know, all these facts and figures and numbers, they could be made real if we do appropriate research. So I think Somalis, wherever we are, we have a role and we can lead the country towards the progress that we desire. Thank you.
Okay. Thank you, Professor Umar. I wish you touched upon the telemedicine, but maybe Dr. Jama would tell us a little bit, very shortly, maybe 2 lines about the telemedicine. But the last question I want to ask Dr. Mohamed Jama is this. So this is a 10-year plan of the universal healthcare coverage that we're aiming for. So you've mentioned earlier the burden of disease, the shockingly neonatal disease and communicable and maternity disease was 68%, where the non-communicable disease, which is quite prevalent here in UK and Western countries, in Somalia is around 22.3%. So looking at this really shocking figure, 68%, do you think in 10 years we would achieve the goals that you've set out? And what pitfalls do you think we might have? And just before you answer that, could you maybe perhaps talk about the telemedicine? I think we had a private conversation about this, so maybe that would be useful to some of our members to hear about that.
Yeah, thank you very much. And I think this is one way also the diaspora can participate. There are already successful experience in certain parts of the country where doctors in the diaspora are connected to those hospitals and health facilities, clinics, and providing, consultation and expertise on how to deal with case. For example, Somalia has a very small number of psychiatrists. And there are a good number of psychiatrists of Somalis abroad. And I know that this has been successful, for example, in Burao area. I know also, I heard also in Bosaso, there was this kind of arrangements where at a given time, a fixed date, at a given time, those doctors will invite their patients and they connect to these doctors in Europe or elsewhere, and they will provide, they will speak actually to the patient directly in Somali, because they are Somalis, and they will, as if the patient was sitting in front of them. So this is very, very useful. Just 2 months ago, Somalia has received the equipment, which is quite significant in terms of numbers, where we hope that in each of the federal member states, there will be one additional center that will have those facilities to connect remotely. And there are also some NGOs and institutions in Europe or North America who are interested to join that effort and provide, and even if we can connect them, not done yet, even in the operation theater, in surgical, interventions where they will need and be guided. So there is this plan, which is not yet fully functioning, except the consultation part in parts of the country, but the equipments have been received, and we need more of those to connect. One thing that Somalia works is the telephone and telecommunication and the internet. It's really very fast and very cheap, and they can be connected. The plan now, if I may come back, you're absolutely right. And that's why the design of our package of services is costing that much, because we believe that 80 to 90% of the interventions that can address the high neonatal child maternal mortality rates and communicable diseases can be delivered at that primary healthcare level with a reasonably cost that is affordable. That's affordable, which is very important. What are we doing about this? There are programs now that are training. Professor Maya has touched on. For example, there is the lady health workers in Somali, Marwa Afimat, who have been trained and is being actually trained with the investment from the World Bank. World Bank is going to invest in Somalia health sector for the next 4 years. And Marwa Afimat training is one of those. We want skilled birth attendants that are recognized by the community and have some confidence, command some confidence and reliability at community level, who can advise when the woman is pregnant, where she has to seek, and recognize danger signs and refer them to the next level, which did not exist before. The continuum of care from community, if Marwa Afimat in a village sees that this woman is something that she cannot understand and is having problems of, I don't know, edema or etc., pre-eclamptic stage, then she can refer to the next level where they can be attended. We want to increase also institutional deliveries. Today, it's only about 27% of deliveries take place in institutions. We want to increase that one, whereas 32% of all deliveries in Somalia are attended by a skilled birth attendant. This saves life. This saves, newborns, lives and mothers' lives, so that they can be addressed. So there is this plan. What I want to tell you also lastly, that the 10-year plan that we have developed, the service delivery package, is not rigid. And we are going to revise every 2 years. We are going to revisit those interventions. We are going to look if we get more resources and shift, interventions from lower to higher level or higher level to lower level, preferably. And we want to improve. So it will not be as rigid as the one that we had from 2009 to 2019. So this will be a living document that will be revisited every time, inshallah. Thank you.
Okay. Thank you very much. So last question, hopefully it will be one-line answer to close to Professor Umar and Dr. Jama as well. I'll start with Professor Umar. This was a very inspiring talk from both of you. So how do you think we can reduce the brain drain of Somali trained physicians in the future? And the same question goes to Dr. Mohamed Jama.
I think, there we go. Just bear with us. I think we're having.
How can we reduce the brain drain of the health professionals? Very important question. We have lost already a lot. Is this the situation we are in now? Mohamed will tell us more. Why people migrate to other countries? I think the first thing is to address the causes of migration of health professionals. In Somalia, I think now the health professionals are migrating back, are going back, and I'm sure everybody of ourselves, whenever we get the opportunity, we will go back rather than run away from it. My long-term plan is making sure that the training programs that we are going to design to our health professionals are tailor-made, are relevant, and are not necessarily of relevance to countries overseas. I think this was an old idea that many countries now are trying to embrace, because we cannot afford to produce doctors who will not serve our people, but instead go and serve other people, which is going to be difficult, because during our days, we used to be educated with taxpayers' money by the government. And so we feel obliged to give back what was given to us. Now, as the universities are all private, people are joining universities as an investment to become a doctor, to become a nurse. And if it doesn't give them the return they expected, they will leave. So a very complex question, because there is no one simple answer to say by doing that, we will reduce migration. Over to you, Mohamed.
Yeah, I would agree with you. For example, I will give you an example. There was a year ago, 2000 actually, last year, Somalia has around 16 or 17 midwifery schools. And two of those midwifery schools, the graduates of those these two midwifery schools have all joined the private sector. They were all trained with public money given to Somalia. So one of the donors who paid the money, part of the money, came to me and asked me, but you see, none of them came to the Ministry of Health. I said, as long as they don't go outside the country, they are really doing a good job, because if they can join the private sector, which is one of our delivery channels in Somalia and service delivery, and they are still in the country, we are quite very pleased. So the answer would be, in my view, train more people. We don't have a strategy in Somalia to train people to export them. Like, for example, the Philippines. The Philippines have a strategy, a national strategy, where they train nurses just for, to export them outside the country. We don't have that. So I think our answer would be, my answer at least, let's train more people. Let the government policies change as well to make it more attractive for doctors to work. The salary scales that are, when Professor Maya and I were working for the Ministry of Health at the time, if I tell you my monthly, and we were the highest paid in Somalia at the time, but it was more than enough for my family and myself. Actually, I could even save some of them. Today, it will not buy you a cup of milk, or a tea. So the salaries are increasing, but I think as the economic development can only be developed when more educated people come into the market, whether it's the private or the public sector. So I think the government should have those policies of inviting and involving. I would expect that such meeting, for example, the British Somali Medical Association, to host their next meeting, let's say in one of the cities in Somalia, where you go there and visit them and broadcast from there, so that people encourage. And I agree with Professor Maya that there are many Somali diaspora that are going back to establish themselves and work and contribute to the community. So there's no simple answer, as Dr. Maya said, but I think we have no choice. We produce, this is the same phenomenon everywhere, and we hope that we will succeed, inshallah.
Thank you very much, Jazakallah khair. That concludes the end of our session. I mean, there's so many more questions people are asking, I want to ask, but we ran out of time. So thank you very much, Professor Maya Umar, who is Professor of Health Management Policy and Planning. He is also advisor to the government of Somalia, and also our main guest, Dr. Mohamed Jama, or also known as Dr. Beydhabo. He is a former assistant director at the WHO. Thank you very much to both of you. I just want to remind everyone that on the 23rd of April, we have Professor John Rees from the King's Somaliland Partnership, who will be giving the next talk. With that, I conclude this session. Thank you very much for everyone who joined us. To everyone who joined us, thank you.
Thank you.